Welcome to this online presentation on obstructive airway disease. What we'll be covering off on today is an introduction to obstructive airway disease, chronic bronchitis and emphysema, the management of COPD, then we'll discuss the pathophysiology and the findings of asthma, and the management of acute asthma attack in the pre-hospital setting. 14.5%, or 1 in every 7 Australians 40 years and over, have airflow limitation of the lungs. This figure increases to 29.2% in Australians 75 years or over. 7.5% of Australians 40 years and over have COPD, and this has progressed sufficiently where it affects their everyday life. Despite the falling death rates, COPD is still the leading cause of death and disease after heart disease, stroke, and cancer. COPD is a preventable disease, however, it is not curable. There are things that people can do to breathe easier with the disease and to keep out of hospital and improve their quality of life. There are 3 diseases that make up obstructive airway disease. This is chronic bronchitis, emphysema, and asthma. Often these diseases can coexist together, more so in chronic bronchitis and emphysema. These two diseases together are called chronic obstructive airway disease, and it's very common that if someone has chronic bronchitis, they would have a degree of emphysema and vice versa. Risk factors for obstructive airway disease include smoking. 95% of all cases of patients with COPD or obstructive airway disease is a current or previous smoker. Air pollution plays a big factor as well, particularly for patients who have worked in industrial or in the mining industry. Patients that have had a low birth weight, patients that come from low socioeconomic status, and patients that have experienced multiple chest infections. The general signs and symptoms included in obstructive airway disease are dyspnea, difficulty in breathing, a productive cough, sputum changes, wheezing, and chest tightness. To start with, we'll discuss the condition called chronic bronchitis. Chronic bronchitis is a condition characterized by inflammatory changes to the bronchioles, which results in excessive bronchial mucus production in the bronchial tree, inflammation of the cells within the bronchi, and the formation of a mucus plug. And this is all a result of inflammatory changes to those cells called hyperplasia, which is excessive reproduction of those mucus-producing cells, and hypertrophy, which is enlargement of those mucus-producing cells. Chronic bronchitis is a result of prolonged exposure to irritants such as cigarette smoking, and remember we've stated already that 95% of all cases with chronic bronchitis is a result of cigarette smoking or industrial smoke and fumes. Chronic bronchitis is diagnosed clinically by a patient presenting with a cough with sputum production on most days for at least 3 months of the year for 2 consecutive years. So as you can see, this is not a rapid diagnosis that is made. These patients are often monitored for a year or 2 and then diagnosed with their condition. Due to this chronic inflammation of the bronchi, narrowing of the airways, and the mucus production that occurs, the patient has a major difficulty in achieving an adequate tidal volume, and most patients are in a state of chronic hypoventilation. Patients with chronic bronchitis are nicknamed the blue bloaters. This is because their signs and symptoms generally include the patient appearing cyanotic, particularly on exertion, and these patients will generally, not as a rule, but generally be overweight due to the chronic dyspnea they experience, particularly on exertion. So they live very sedentary lifestyles and don't do a lot of exercise at all because they really struggle to breathe when they're walking around or just a short trip up the stairs. Often these patients become overweight. The disease is characterized by excessive mucus production and a productive cough. In most patients with a respiratory insufficiency, you can find signs and symptoms such as finger clubbing or clubbed nails. We've got a diagram or 2 diagrams on the right hand side over here to show what finger clubbing looks like. If you take a few seconds to look at your own fingernails, if you put your fingers directly in front of you and observe the shape of your fingernails, they are often looking very straight from the nail bed right to the fingertip. Whereas in patients with chronic respiratory insufficiencies, such as in COPD or chronic asthma, the fingernails take on a slightly different shape. This is a pathological response to the chronic hypoxia that they experience. Their fingernails actually grow in a convex shape. This can also occur on the toes as well, so not just on the fingers. On auscultation, you may hear coarse rhonchi and wheezing together. This is due to the chronic inflammation with the mucus production and that bronchoconstriction that occurs. Patients with chronic bronchitis suffer from what's called a ventilation-perfusion mismatch, and this results in hypoxic hypoxia. So I have a diagram on the next slide to show you what this looks like. So with ventilation and perfusion occurring in the lung, if we just have a look on the right-hand side of the diagram over here, this is what's a normal alveoli would look like. We have an easy flow of air into the lungs during inspiration, right down to the alveoli. And as the pulmonary blood flow comes past the alveoli and perfuses it, there's an equality with the amount of ventilation that takes place and the amount of perfusion coming past that alveoli. Now, in the event that the patient has chronic bronchitis, and that's depicted on the left-hand side of the picture over here, that we have that narrowing of the bronchioles inhibiting the airflow down to the alveoli. We still have normal perfusion going past that alveoli, but in this case, there is not an adequate amount of ventilation to match the amount of perfusion. This will result in hypoxia, not enough oxygen being transported around the system and being utilized at the cells. In very severe cases of chronic bronchitis, as there are significant pressure changes inside the lungs for a long period of time, this can lead to what is called pulmonary hypertension. So the blood flow going through the pulmonary circulation is under high pressure. Now, as the right side of the heart is responsible for pumping blood through the pulmonary circulation to the left side of the heart, when there is pulmonary hypertension, the right side of the heart has to work a lot harder than it would have to do in a normal lung. With this excessive workload on the right side of the heart, this can lead to enlargement of the right side of the heart and then what's called heart failure or cor pulmonale. When the right side of the heart begins to fail, there's a backup of blood through the system. This can be seen in signs and symptoms such as jugular vein distension, because blood is backing up through the superior vena cava and into the jugular veins. And there is ineffective circulation in general as a result of the right-sided heart failure. Due to this ineffective circulating blood volume, the body reacts by activating the renin-angiotensin-aldosterone system. And what this system does is it tries to prevent a loss of fluids in the body, and it causes fluid retention. So as you can see, chronic bronchitis can have really, really severe long-term effects for patients if it's not managed well. Emphysema is a result of pathological changes to the alveoli, which happen slowly over many years. It's characterized by abnormal enlargement of the air spaces beyond the terminal bronchioles. Just like chronic bronchitis, chronic irritants to the lungs, such as cigarette smoking or fumes or toxins that are breathed in from the atmosphere, damage to the alveoli, and an inflammatory response. Chronic exposure to inflammatory chemicals result in damage to the alveolar septum, which results to failure to maintain the shape of the alveolar integrity. As the septums start to degrade or disappear, we actually lose lots of surface area available for gaseous exchange. So as we can see in the diagram over here, instead of having multiple small little air sacs or alveoli, we now have one larger air sac, and that actually reduces the size of the surface area that's available for gas exchange to occur on. As with destruction of the alveolar walls and the loss of integrity, So also there's a loss of elasticity and ability for these alveoli to recoil again during expiration. If these alveoli lose their elasticity and their ability to recoil, it results to air trapping within the lung, and this in turn decreases the effectiveness of ventilation. These inflammatory chemicals also have effect not just in the alveoli, but in the capillary beds surrounding the alveoli too, which can reduce perfusion through pulmonary circulation. In contrast to the blue bloaters that are described in chronic bronchitis, emphysema patients are nicknamed the pink puffers. Some characteristics of the patient with emphysema is this barrel-shaped chest that we see in the diagram over here. So convex chest on the front and the back. This occurs as a result of chronic air trapping in the chest and the regular use of accessory muscles during respiration. Usually expiration is a passive process, but with patients with air trapping in emphysema, it becomes an active process where they have to engage accessory muscles in order to aid expiration. These patients can then often be quite red in the face due to the forced exhalation. This relates back to their name as the pink puffer. Often these patients will purse their lip. They do this as a subconscious action during forced expiration. Characteristically, patients with emphysema are generally thinner than those with chronic bronchitis due to their poor dietary intake and increased work of breathing. Patients with emphysema may develop what is called blebs, which are small collections of air in the visceral pleura due to destruction of the alveolar walls and that chronic inflammation. Due to the inadequate ventilation and decreased surface area for perfusion to occur over, you would suspect somebody with emphysema to have a VQ mismatch. But because these patients also have poor perfusion due to the damage of the capillaries around the area, they actually have what's called a matched VQ mismatch. Translated, that means we have decreased ventilation, but we've also got decreased perfusion. And so this actually works out quite well in a strange way. Due to the decrease of oxygen around the body, there is an increased red blood cell count in these patients. And just as an added note into the signs and symptoms you may see, similarly to that in the chronic bronchitis patient, emphysema patients, due to the massive air trapping in the thoracic cavity and those increased pressures, can also have pulmonary hypertension, leading to right-sided heart failure. And here we have a diagram depicting the different types of air trapping that happens in COPD. On the left side of the page, we have a picture depicting the chronic bronchitis air trapping. So this is due to a narrowing and inflammation of those bronchioles, bronchioles being the key word, with the formation of the mucus plug. So air can move in all right, but during expiration, air has difficulty leaving the bronchioles. So air gets trapped in the alveoli, expanding them. In the emphysema patient, which is depicted on the right-hand side over here, there's also a slight narrowing of the bronchioles because of inflammation, but the major problem here is because of the destruction of the alveolar walls and the loss of elasticity, the alveoli do not recoil effectively during expiration, so not much air actually leaves the lung, and this leads to air trapping in the alveoli. The disease process of chronic bronchitis has to do with the bronchi and the bronchioles, whereas the disease process with pulmonary emphysema has to do with destruction of the alveoli. So if we were able to see internally, it would be very easy to differentiate which condition they were suffering from predominantly. Here we have a picture and some signs and symptoms which can help you to differentiate between the two. And the biggest things to highlight here is with the blue bloaters, we're looking for discoloration, particularly cyanosis. Generally, this patient's going to be more overweight, and you're going to have the history of that chronic productive cough for more than 3 months in 2 consecutive years. In the patient with pulmonary emphysema, we're going to be seeing that barrel-shaped chest, use of accessory muscles to breathe, pursed lips during exhalation, and because of the excessive exertion while breathing, these patients may be slightly thinner. Regarding the management of the COPD patient, follow your DRS ABCD, checking airway, breathing, circulation, and deformity. Assess the medical history, vital signs, blood sugar levels, pulse oximetry, and ECG. Provide airway management as necessary. Assist ventilations if needed. Obtain IV access if this is required. In regards to oxygen therapy, some patients with COPD rely on the hypoxic drive. So with oxygen administration, this can decrease their respiratory drive. Be cautious about administering high concentrations of oxygen to these patients. However, we will never withhold oxygen in an emergency situation. In regards to other medications to administer, if the patient has got wheezing on their chest and clear signs of bronchoconstriction, we need to administer beta-2 stimulants such as salbutamol. This is 5 milligrams in a 2.5 ml neb. And we can nebulize this with anticholinergics such as Atrovent, otherwise known as ipratropium bromide. And the doses we administer for this is 0.5 milligrams in 1 ml, and we nebulize that with salbutamol in the same neb. These patients may also respond well to corticosteroids. Just depending on your organizational protocols and where you work, you may or may not be able to actually administer these. Having a look now at asthma, it's a chronic obstructive airway disease which is characterized by a bronchoconstriction or bronchospasm with excessive bronchial secretions forming a mucus plug and inflammation of the bronchi and the bronchioles. How this differentiates to chronic bronchitis is although asthma is a chronic disorder, there are only short bursts of acute attacks, whereas the chronic bronchitis patients' airways are chronically inflamed, producing those secretions and mucus plugs. Exacerbating factors for asthma attacks include things such as allergens. This is commonly seen in children. About 90% of all asthma attacks in children is due to an allergen, and in particular things such as pollen or dust or molds. Chest infections can result in bronchospasms even in patients who do not suffer from asthma, although those who do suffer from asthma who obtain chest infections have much more frequent bronchospasms occurring. Bronchospasms can be stimulated by physical exertion, medications such as aspirin, smoke or toxic fume inhalation, psychological stress, or anaphylactic reactions. Signs and symptoms of an acute bronchospasm can include spasmodic coughing, which is unproductive, a wheeze, which may be initially expiratory wheezing, and as this progresses can become an inspiratory and an expiratory wheeze, and as this progresses to a severe case, this can lead to things such as a silent chest, where the airway has been constricted so badly that there is no air movement in and out, so therefore no sound of wheezing. An inability to speak in full sentences, phrases, or just in words, use of accessory muscles for ventilation, dyspnea or difficulty in breathing, and tachypnea, fast breathing. Patients may assume the tripod position as they find this a lot easier to be able to expand their lung volume, and they may depict a high level of anxiety because of their inability to feel like they're ventilating properly. We may start to see signs and symptoms of hypoxia and cyanosis with a tachycardia, diaphoresis or sweating. And in severe cases, you'll start to see signs and symptoms of hypoxia. There may be a silent chest, so you may not hear any inspiratory or expiratory wheezing. There can be a decrease in the level of consciousness. And due to the high interthoracic pressures, there's poor venous return to the right side of the heart, resulting in a backup of blood into the jugular vein, so you can often see that jugular vein distension, and this can also result in decreasing blood pressures. If there's a decrease in systolic blood pressure of more than 10 millimeters of mercury during inspiration, this is a condition that is called pulsus paradoxus. As time goes by and patients are using accessory muscles for breathing, patients start to become very tired, and if the bronchospasm is not relieved effectively, the patients start to exhibit poor respiratory efforts. When assessing the severity of the bronchospasm or the asthma attack, the signs and symptoms are categorized as a mild attack, a moderate, a severe, or when respiratory arrest is imminent. In the mild bronchospasm, the patient may start to experience breathlessness when walking or going up a flight of stairs. They are still able to lie down without having respiratory difficulties. They can speak in full sentences. They may be slightly agitated but alert. No sweating, only a slight increase in their respiratory rate. They usually have not engaged the use of accessory muscles at this stage. There may only be a slight expiratory wheeze. In the moderate bronchospasm, breathlessness can occur on minimal exertion. The patient would prefer to be sitting upright and has major difficulties laying down. The patient is now reduced to speaking only in phrases. They can start to feel agitated and anxious due to their difficulty in breathing. They may start sweating. There will be an increase in their respiratory rate. They can start making use of those accessory muscles during respiration. And you're going to hear a loud, audible expiratory wheeze. In the severe bronchospasm, the patient may experience breathlessness at rest. They'll be sitting in that tripod position, hunching forward and leaning on their legs to try and increase their interthoracic volume. Their speech is reduced to only being able to speak one word in between each breath. They're usually very agitated and starting to show signs and symptoms of hypoxia. They're sweating profusely, and often their respiratory rate can increase above 30 breaths per minute. These patients are really laboring to breathe. They're making use of accessory muscles, and we may even start seeing a suprasternal retraction and tracheal tugging. Wheezing is still loud at this stage. We'll hear an inspiratory and an expiratory wheeze in these patients. When respiratory arrest is imminent, the biggest thing to remember here is the patient has a decreased level of consciousness, and there are going to be absent chest sounds, so what's called a silent chest, where there's actually no air passing through those bronchioles to the alveoli. When assessing the medical history of the asthmatic patient, it's important to ask what medications the patient is on and have they taken their meds. Often patients have run out of medication, and that's why they are now calling you or approaching you, or they have forgotten their inhalers. Check the expiry dates on the patient's medication if they're available, and ensure that the patient is taking their inhaler correctly. Ask the patient to show you how they use their inhaler and get them to take one puff. Ask the patient about how many times they have used their puffer, and ask what they think might have been the cause of the attack today. Ensure that you are checking the patient's temperature and asking about history of possible infections. When dealing with a moderate to severe case, ask the patient if this is the worst episode of bronchospasm or asthma attack that they have ever had. Ask them if they have ever been hospitalized for the asthma attack. So this means actually staying overnight, not just going to emergency. And ask them if they've ever been intubated. With patients who have previously been hospitalized for long periods of times or have been intubated, have the capacity to get to that really severe state again. So it just gives us an early warning to rapidly move these patients to hospital where they can get further care. In the first aid management of asthmatic patients, family members and caregivers are taught the 4x4x4 technique. This is to aid in the effective administration of the Ventolin through the puffer. In the event that a spacer is available, always use it, because spacers have been proven to be even more effective than nebulizers in treating the asthmatic patient. With a spacer available, what you do is you attach the puffer to the spacer, make sure that the puffer has been shaped well, place a mouthpiece between the child's teeth and lips. Make sure they've got a good seal around the spacer. Press the puffer once to administer 1 dose of salbutamol. Ask the patient to take about 4 breaths. Repeat 1 puff at a time until 4 puffs are taken altogether. Wait for 4 minutes and then reassess the patient. If they are still showing signs and symptoms of the bronchospasm, you can repeat the process until help arrives. If, however, there is no spacer available, what you do is again remove the cap, shake the puffer well. Place the mouthpiece between the child's teeth, ask them to put their lips around the mouthpiece, Ask the child to exhale as much as they can, and when you press the puffer in firmly, the child must take a deep breath and hold that for 4 seconds and then breathe out again. Repeat this process 4 times. Remove the puffer, wait for 4 minutes, and reassess the patient for signs and symptoms of a bronchospasm. And again, if there are still signs and symptoms present, this process can be repeated again. The pre-hospital management of an asthmatic patient experiencing an acute bronchospasm includes conducting a DRS ABCD assessment and medical history, assessing the vitals, blood sugar level, pulse oximetry, and ECGs. Provide airway management as necessary, assist in ventilations if this is required, obtain IV access to keep the vein accessible for medication administration, provide oxygen to these patients as soon as possible. We're going to be providing medications via nebulization and intramuscular injection in the severe case. And in severe cases with air trapping, we can provide expiratory assistance via lateral chest thrusts. So just having a closer look at these different types of medications we can use, starting off with beta-2 stimulants, and in particular salbutamol. Beta-2 stimulants act on the bronchioles by causing bronchial dilation. So this stops the bronchoconstriction and opens up that airway for normal ventilation to occur again. How we administer this is through a nebulizer, and we administer 5 milligrams in a 2.5 ml nebule. This is to be repeated every 5 minutes if signs and symptoms persist. In certain organizations, you can also obtain salbutamol IV, which can be administered in severe cases when we have silent chest and no air movement is occurring, and the salbutamol that is being nebulized isn't even getting down to the bronchioles. Anticholinergic medications such as Atrovent, or also known as ipratropium bromide, can be nebulized in conjunction with salbutamol. How anticholinergics work is they block the parasympathetic nervous system, which is responsible for the bronchoconstriction and those secretions on the bronchioles. So it helps again with bronchodilation and stopping those bronchial secretions. We administer 0.5 milligrams of Atrovent in a 1 ml nebule, and this is to be mixed with salbutamol in the nebulizer, and it has a very long-lasting effect of about 4 to 6 hours. So we actually only repeat this dose once in patients with bronchoconstrictions. Depending on the organizational protocols and where you work, you may be required to give things such as corticosteroids called prednisone or Solu-Cortef. These are administered via IV to decrease the inflammation, in particular if this is a result of an allergic reaction or a result of infection. In severe cases of life-threatening asthma, adrenaline can be administered as an IM injection. Adrenaline works on the beta-2 adrenergic receptors and is a powerful bronchodilator, but this is only indicated in the life-threatening asthma patient with a decreased level of consciousness and silent chest. Sustained lateral expiratory chest thrust is recommended in cases of severe life-threatening bronchospasm which is unrelieved via medications. It is also an effective technique for supporting respiration in the asthmatic casualty whose respiratory muscles are starting to tire, and it can aid in exhalation during the ventilation cycle. So it's indicated for patients with severe life-threatening or unrelieved asthma who are hyperinflated and there is no or little air movement, or when ventilation due to asthma is difficult because of the high resistance pressures in an arrest. The technique of doing lateral chest thrust is by placing both hands on either side of the lower lateral chest wall. Spread the fingers out to reduce any pressure points. The little finger should be lined up with the lowest rib, and the thumb should be aligned with the mid-clavicle. Compress the chest medially towards the spine and slightly upwards, synchronizing this with the patient's expiratory effort. Watch the patient's movements of their chest to ensure that you are not compressing during inspiration. During resuscitation ventilations, only start to conduct once each positive pressure ventilation has been completed. Again, we do not want to compress during the inspiratory period. Compressions should be slow, rhythmic, and sustained pressure should be held in place to help force the air out. Also, a slight vibration of the hands during this compression can assist in the exhalation. But just remember, this is only to be conducted on the patient where, whatever. Status asthmaticus. Status asthmaticus is a severe prolonged asthma attack that is unresponsive to repetitive doses of medications. It's a true medical emergency which requires early recognition and immediate transport, as respiratory failure may be imminent. In addition to the signs and symptoms of a severe asthma attack, these patients are typically dehydrated due to the excessive lengths of In addition to the signs and symptoms of the severe asthma attack, these patients are also typically dehydrated. Management of the status asthmaticus patient is the same as a severe or life-threatening asthma attack with added fluid resuscitation. Which comprises of 20 mils of IV therapy of 20 mils per kg administered rapidly with a reassessing the patient afterwards. Go. Thus concludes the presentation on of obstructive airway diseases. Thus concludes the presentation on COPD and asthma.